Hello there and welcome. My name is Jameson Hake. I'm a current PGY-2 at Michigan State's Physical Medicine Rehab Program. Today we'll be chatting about sacroiliac joint pain. First, let's talk about the bones that make up the joint. We have the sacrum and the ilium that combine to make a diathrodal joint. The superior third is more stable, as contributed by the cartilaginous structures that are more prominent in that area. And the inferior portion of the joint has more characteristics of a synovial joint. Joint space and motion can decrease with age, but does not truly fuse with normal aging. There are many ligaments that cross the SI joint, including the anterior, interosseous, posterior, sacrotuberous, sacrospinous ligaments. And there is minimal movement within that joint with rotation maximally at 2 to 2.5 degrees, some minimal translation, which is impressive considering the large surface area of the joint. SI joint innervation is poorly understood, but is postulated that the anterior portion is innervated by the sacral plexus, the posterior portion innervated by L4-S1 nerve roots with maybe some contribution from the superior gluteal nerve, and maybe some input from the sacral dorsal and ventral rami. As we all know, low back pain is extremely common within the population and can affect up to 70% of the population. SI joint pain is often underappreciated, although some say it may be overappreciated. Studies have suggested that SI joint pain makes up about 30 to 30% of the chronic low back pain population. When considering low back pain, we should also consider other anatomical features nearby, such as the low back, the hip, and nerves, as well as neurological, oncologic, and inflammatory causes of pain in the area as well. Clinical presentation can vary, but unilateral SI joint pain is more common than bilateral SI joint pain. Athletes that are involved in unilateral repetitive loading, such as kicking or jumping, can be more vulnerable to injury. As depicted on the right here, kickers from various universities can also display superior-inferior performance as well. Trauma can be a contributing factor, as well as pregnancy and childbirth. There hasn't been any specific association in differentiating between low back pain or other causes of pain along the SI joint in clinical history that would help you separate SI joint pain from those other aforementioned areas of pain. When considering SI joint pain patients, consider those that have had previous spinal fusions. A study conducted by Simmons found that when comparing lumbar fusions versus lumbosacral fusions, those with lumbosacral fusions were more likely to have SI joint pain, as evidenced by 30% of those with LS fusions having SI joint pain following the surgery, and only 18% of those with lumbar fusions having pain, thus suggesting that there's an increase with SI joint pain following the LS fusions. Patients with SI joint pain predominantly present with buttock pain, low back pain, but can also present with groin, lower extremity, and foot pain. But overall, these pain referral patterns are not particularly helpful when separating diagnoses of SI joint pain and other aforementioned differential diagnoses. The sacroiliac joint can be visualized with multiple modalities, including MRI, plain radiographs, CT, and radionuclide bone scanning. However, given all these advancements with imaging, there has not been good correlation with pain and positive results or negative results on imaging, as well as positive outcomes with sacroiliac joint injections and findings on imaging. So how do we diagnose SI joint pain? The ISAP came up with 3 simple tenets in 1994 that included pain being present in the SI joint, pain being reproduced with clinical stress tests on physical examination, and direct injection completely resolving the patient's pain. While these tenets may be simple and vague and sound good on paper, they haven't been expanded upon since 1994. So let's take a look at the literature and see what constitutes the diagnosis of SI joint pain and the treatment, specifically how to pick a patient using physical exam techniques. Schneider completed a prospective cohort study that involved 36 patients and evaluated the patients using pre and post fluoroscopy-guided steroid injections, evaluating physical exam techniques before and after. Their study suggested that there was no one physical examination or cluster of physical exam techniques that contributed to a positive increased likelihood of having a positive result with the injection. Similarly, Dreyfus completed a study of 85 patients with pre and post testing using the following physical exam techniques, and again found that there was no single exam maneuver or cluster of exam maneuvers that were likely to predict positive response with the injection. In contrast to the previous studies, Vanderwerf completed a study of 60 patients. 27 of those who had responded to these results had 3 out of 5 tests of physical exam tests positive, suggesting that there is a sensitivity of 85% and a specificity of 87% with a cluster of techniques and a positive result with injection of the joint. Laslett also completed a study that had 48 patients, and they had similar results as Vanderwerf and included that there was a sensitivity and specificity for 3 or more of the tests being positive of 94% and 78%. They also stated that if all 6 tests were negative, that painful SI joint pathology could likely be ruled out. So this is a common crossroads that we come at with the pursuit of practicing evidence-based medicine that can be frustrating. We have conflicting evidence as suggested with the previous literature. And so where do we go from here? So Dreyfus completed a narrative review of the current literature involving SI joint pain and concluded that in the absence of any positive physical exam maneuver, SI joint pain is unlikely. With an increasing number of positive physical exam maneuvers, the diagnosis of SI joint pain becomes more likely. But given the conflicting evidence amongst these studies, there's no definitive conclusion that can be reached. And there's no physical examination that's pathognomonic for SI joint pain. So they postulated that there's potentially more going on in the area than we are appreciating. And so it's possible that not only the SI joint is contributing to SI pathology and pain, and there could be extracapsular ligaments, and we need more information research in order to best treat and diagnose this. So let's look at these techniques. We'll be looking at the following techniques here, many of which were referenced in the previous studies. And without further ado, I'll send it over to Dr. Zafarian at I.
You want me to go through the exam for the SI joint too. So it kind of correlates with the hip. And some of you guys have heard me say this before too. So he'll go through some of the evidence where they have 3 out of the 5 positive exam findings correlate with SI joint pathology. And then one of the guys for CIS came up with the guidelines. So now you need to document 3 positive exam findings for most insurances to be able to do a diagnostic and or therapeutic SI joint injection. So I'll kind of go through some of them, and then I'll tell you what I do. So first what I'll do is I'll do full hip flexion up here, and then I'll get them in this position. And some of you guys have also heard me talk about the difference between Faber, so F-A-B-E-R, and Patrick's. Typically how I do it, and this is how I document it, is I'll get them in this position, and I'll call this Faber. If they have pain going into the groin anteriorly, I'll call it positive Faber. So that means it's more anterior hip groin pain. If I push and it still causes pain anteriorly, I call it positive Faber. Now if I push while stabilizing the contralateral ASIS and pelvis and it causes pain in the back along the SI joint, I'll call that positive Patrick's. So posterior Patrick's, anterior groin hip Faber. Okay? And then you can go to against the lines when they're in this position. It's kind of similar to Thomas test. So essentially you take them, the ipsilateral leg off the table. Okay, then you bend the contralateral hip up and you'll push down on the ipsilateral thigh. And if that causes pain in the SI joint area, that's a positive Genselon's test. Okay, SI distraction test. That's just if you push here, okay, and it causes pain in one of the SI joints, that would be positive. Okay, then you can roll them on the side with the ipsilateral painful side up. Okay. And you can put pressure here. That's called the SI compression test. Okay. The other way you can do it is if they're prone on their belly. And I'll do it this way. This is kind of the DO thing where we would rock the sacrum. If those of you guys that went to MSU COM, you could rock the sacrum and do kind of SI compression in here. This is the one that I do mostly clinically, and I'll push on it, and I'll tilt it towards either side and see if you're getting pain by doing the SI compression that way. So the thigh thrust is if you get the hip flexed to 90, adduct a little bit, and you put pressure through that thigh while monitoring with your left hand or the opposite hand on the SI joint. If that causes pain, that's positive thigh thrust test. And the last one is a clinical one where they'll point to their area of pain. Let's stand up. And they'll point to the painful SI joint, and that's called Fortin finger, F-O-R-T-I-N, Fortin finger sign. So they don't, for insurances, they usually don't count Fortin finger. This is one that you guys will see me use the most, Yeomans. It's Y-E-O-M-A-N-S. It's almost exactly like reverse straight leg raise, but it'll cause pain in the back. So I'll keep this leg straight, and then I'll extend it, and if it causes pain in the SI area, then I call that positive. So those are the three ones I do: compression, Patrick's, and Yeomans. And I'll also document Fortin finger. Anything else that I missed? Nope. Cool.
So now that we know how to select a patient for an SI joint injection, let's take a look at the current literature involving SI joint injections. Kennedy did a literature review that looked at the various studies involving SI joint injections, and overall the evidence for effectiveness of SI joint injections is about moderate. There were a couple randomized controlled trials that were completed, observational studies, and of note, there is no placebo-controlled studies. And there was a variety of results from the studies that were found. Before performing an SI joint injection, we need to make sure that we understand the joint itself. And the joint volume within the SI joint is about 1 to 2.5 cc's. And typically one uses a cc of the steroid of their choice, as well as 1 cc of local anesthetic. The needle of choice usually is a 22 gauge, 3.5 inch spinal needle. Following SI joint injections, the most common adverse effect seen in patients is increased pain, which can be seen in about 24% of patients. Occasionally, a temporatic sciatic palsy has been reported, as high as 6.2% of patients. But what about the effectiveness of ultrasound versus fluoroscopy? Stelzer completed a study using 20 cadavers in total, 10 for each group, each cadaver having 2 SI joints. There was 20 injections completed per group. They used a latex injection that was found to be effective in about half of the injections in the fluoroscopy group, but only 1 out of 20 injections were found in the SI joint itself with ultrasound. There were some limitations to this study in that obviously you're using cadavers and not real patients, and that the latex doesn't extravagate like a normal local anesthetic and steroid would. Let's take it back to Dr. Zafarian over at IDE to see how the injections are.
Hey guys, Jameson asked me to go over SI joint injection here. So we have the setup, patient's prone, okay? This isn't a cadaver. It's just a little bit more useful than a cadaver, but not by much. So what we do is patient prone, oblique the C-arms, because the way the sacrum's set up, like the sacrum's going to be wider in front and skinnier in the back. Okay, and that makes sense physiologically too, right? Because if it was square or the opposite, it'd be easy to dislocate that sacrum out of the pelvis, right? So that's kind of a stopgap, being narrower in the back and wider in front. So then what happens is you're going to see 2 joints. If you go straight anterior posterior, you'll see 2 lines as you're shooting through that. So to line them up, you got a contralateral oblique, and you'll see here to line up and make 1 joint there. All right, so we stay in the lower aspect of the joint. Lower third is where you want to be at the most inferior part if you can. So then what we do is mark the skin, use lidocaine, take the needle down to that area, and then typically what I'll do is I'll go to a lateral view, make sure that you can see the depth of your needle, make sure you're through to the joint, and then come back. And when I come back, I don't come to the contralateral oblique view. What I'll do is go to AP. So then here you just see 1, and then now you'll see 2 joints. So the lateral is going to be the anterior joint. The medial is going to be the posterior joint. So then when I come back, I should see my needle coming at an angle to that posterior joint. And then from this view, I'll inject contrast. You should see it surround the joint and flow with an intra-articular flow pattern. And then once you have that appropriate flow pattern, then you can inject. Cool?
We know how to do SI joint injections. Let's talk about the potential of SI pain being extra-articular. And let's return back to the posterior sacroiliac ligament. And it's not difficult to postulate that, as with another joint, such as the hip or shoulder, there are other contributors to joint pain besides the joint itself. There are many ligaments, tendons, and muscles that surround the joint that frequently contribute to pain there. And so it's easy to maybe suggest that the posterior sacroiliac ligaments could contribute to SI joint pain. So Dreyfus wanted to play with this possible scenario that the sacral ligaments may be a large contributor to sacral pain. So what he did was he looked at the effectiveness of sacral lateral branch neurotomy, specifically at the L5 dorsal ramus and the S1 through 3 lateral branches, which is what is thought to be the innervation of the posterior sacral ligaments. He took 20 healthy volunteers that were subjected to noxious stimulation along the posterior ligaments and within the SI joint, using filling of the joint capsule with saline. And he found that he was able to produce pain in all 20 victims. These victims sound a little bit desperate, and they could have been starving, hungry residents. Following his initial torture, he completed a double-blinded test in which half of the patients received a bupivacaine injection at the sacrolateral branches, and the other half received a placebo injection. 5 to 7 days later, the subjects returned for their second round of torture with ligament poking and capsular distension. In the active group, they had 70% of the participants had insensate ligaments compared to 0 to 10% of the control group. And in the active group, 26% of the participants did not feel repeat capsular distension compared to 10% of the control group. And so this study pushes to make physiologic conclusions that the sacrolateral branches innervate the posterior sacroiliac ligament, but not necessarily contributing largely to the innervation of the SI joint. And this is important because historically, radiofrequency ablation was used to block the SI joint. However, this suggests that that's not true, and a better screening method for sacrolateral branch neurotomy would be blocking of these branches with bupivacaine or local anesthetic prior to neurotomy. So if a patient has a good outcome with SI joint injection, they may not have a good outcome with a sacrolateral branch neurotomy because that might not be the innervation of their pain. So what did we learn today? We learned that it's very difficult to select patients for SI joint injections based on history and physical examination. But with multiple provocative tests, we can increase the odds of having an effective SI joint injection. We also learned that LS fusions compared to lumbar fusions likely increase the risk of SI joint pain. We also learned that ultrasound is an inferior injection modality compared to fluoroscopy as far as guidance for SI joint injections. And with Dreyfus's study, we learned that SI joint injections are not great predictors for success of lateral sacral branch neurotomy. And if you want to select a patient for lateral sacral branch neurotomy, you're better off using local anesthetic blocking of the L5 dorsal rami and S1 through 3 lateral branches. So where is the future of SI pain research? Continued research in the benefit of physical examination techniques in selecting patients for SI joint injections could continue to improve, as well as the benefit of SI joint injections themselves, particularly with placebo trials. Further examination with extra-articular SI pain, including sacral branch blocks and posterior sacral ligament pain, can continue to be expanded upon, as well as the effectiveness of PRP and prolotherapy within SI pain. And newer systems that have come to the market recently include minimally invasive fusion technology, such as this Pain Tech link system, which involves inserting a small bone graft posteriorly to encourage fusion. There are a few prospective trials going on, one of which started in June of 2020, and the study is called the Secure study. So be on the lookout for this in the future. There are some other European studies going on that are developing a similar system under a different brand. So I thank you again for listening today. I hope that we are both able to learn something about SI pain today, and here are my sources. Thank you again.